Good evening, everyone. So this is a pre-conference workshop organized regarding this ISSICON. So ISSICON program is planned in the October weekend. So where we will be extensively covering about all aspects of spine trauma as well as spine rehabilitation and recent advances in spine trauma care as well as rehabilitation care, including robotics and everything. So as part of this conference program, we have this pre-conference workshop where we'll be covering some of the topics which may not be covered in the conference, as well as which will be a head start for the program, so that the flow of the program will be easier during the conference. Today we have Dr. Kanagasabai, who is our esteemed senior radiologist in Kauvery Hospital, Chennai. He has extensive experience in UK as well as in India, and he specialized in musculoskeletal radiology. He has worked in a renowned trauma center in UK. He's here with us to share his insights about imaging in spine trauma. Welcome, Dr. Kanagasabai. Hello, sir.
Sir, you're on mute. Kindly turn on the mute.
Hello, Kanagasabai, sir.
Hello.
Hello, sir. We can hear you, sir. You can start your presentation.
Is a PowerPoint?
No, sir, it is not visible, and I think there is some noise.
Okay. Hello. Is the PPT visible now?
Yes, sir. It's visible and you are audible.
Yes.
The host, Mr. Rishi, can you mute all the other audios except Dr. Kanagasabai, please? And sir, you can go on full screen, sir.
Yeah.
Sure, sir. I think the main disturbance is coming from the speaker side.
Okay. Is there any this one? Any disturbance now or?
Yeah, it's better now, sir.
Okay. Is it?
Can you try to removing that headphone, then speak?
Okay. Am I audible now?
Yes, sir. Now it is better.
Now it's better. Okay. Okay. So thank you for providing this opportunity to present in this forum. So I'll be presenting a short webinar on imaging in spine trauma, a radiologist perspective. So I am Dr. Kanagasabai. I'm a consultant radiologist at Kauvery Hospital, Alvarpet. So I have a fellowship in musculoskeletal and spine trauma and worked in Robert Jones Hospital, which is a place called Oswestry. I think most of the spine surgeons might know that. It's one of the selected spine centers in the UK. So, so I won't be going into more into cases today. So the presentation will be based on what is the protocol to be used in case of trauma, because these patients cannot be kept in the scanner for a long time. So I'll be talking about the protocols. So then I will show a few cases, then some selected, some special cases and some recent advances in case of spine imaging, especially in related to trauma. So the standard protocol. So the main aim the two most commonly used modalities apart from X-ray is the MRI and CT. So the aim is to get the scan done in a shorter time. So we should keep the sequences to a minimum. So the standard sequences include a sagittal T1, T2, and STIR. GRE is a must in case of trauma. I'll show the case later. A myelogram. Optional sequences include 3D sequences, DTI, in and opposed phase images. Sometimes when you are suspecting a hemorrhagic cord injury, axial T1 weighted images can be used. CT should be done in a thin bone algorithm with multiplanar reconstruction. If there is a metal artifact detection should be used. Ultrasound in case of spine trauma mainly used in case of to look for any post-operative collections. X-ray standard two views. Additional views can be used in case of a stable injury. Flexion extension studies can be used in case of stable injuries. So I'll show a few sequences. This is a myelogram sequence. This just takes few seconds to acquire. This will give a lot of information in planning the rest of the studies. So these are the standard T1 and T2 weighted images. In a 1.5 Tesla, this is composed. This will be taken in stacks. It will take time to compose this image. With the newer 3 Tesla scanners and in advanced machines, this can be taken in a single acquisition. So that reduces time. And in 3 Tesla, you can use a Dixon imaging. So which will give T1, T2, STIR, and FS sequence in a single acquisition, consistently reducing the time. This is a STIR sequence. This is a sequence which will light up the edema, contusion, injury. So every trauma case should have a STIR sequence. So this will highlight the findings. This is an optional sequence. T1. This is called as an in-phase apostphase image. So this will get a single image, and will reconstruct into an in and apostphase image. So here, so this you can use as a problem solver. This will take less than a minute. This takes around 40-50 seconds to acquire. So this can be used as a plot. Yeah.
Just a second. Sorry for interrupting. But is the PowerPoint slide moving?
I'm not able to hear you, Soma, properly. Hello? Hello?
Sir, your slides are not moving.
Interest, sir. But Dr. Panikaran, sir, can you see the not moving, sir?
Which is this PPT?
Yeah, PPT. Yes. So we are not able from the beginning. We were not able to see any of the slides.
Oh, okay. Can you see it now?
Now we are in the 7th slide. Yes.
Okay.
We can see, but it's not in full screen mode.
It's not in full screen, sir. You can put it in a presentation mode.
It's not in slideshow mode.
Yeah, I'm in the slideshow mode only. So I'm in slideshow mode only.
Sir, you will need to unshare the screen and share the that slideshow screen.
Okay. Is it better now?
Yes, sir. It is better.
So this is the this is a full screen I have shared.
Soma, sir, your mic is on mute.
Can you hear me
Sir,
now?
yes, sir. Now it is visible.
Okay.
If you don't mind, can we have it from the beginning, sir? We were not able to see any of the slides till now.
Okay. Can you hear me also? Can you hear me?
Yeah. Better, sir. Now it is better. Both the slides and
Okay.
yeah.
Okay. Sorry for the technical glitch. Okay, I'll start from the beginning. So as I was saying, so the protocol should include bare minimum sequences. So these, am I audible now? Hello?
Yes, sir, you're audible, sir. You're audible.
And the screen is also full screen, no?
Yes.
Yeah, okay. So the sequences should be bare minimum. So these are the, just 4 or 5 sequences are enough. So which it should include a myelogram, GRE sequence, T1, T2, and stir sequence. So optional sometimes can be used as problem solvers, which include DTI, in-phase, appost-phase, and 3D sequences. CT should be thin bone algorithm should be used with MPR with metal artifact reduction in case of metals. Ultrasound is mainly to look for post-operative collections, don't have much role in the pre-operative imaging. And X-rays, you will use the standard 2 Vs, and additionally, flexion extension can be done in case of stable injuries. So I'll quickly go through the sequences. So this is the MR myelogram. So we acquire this first. So this takes around a few seconds. This takes around 30-40 seconds to acquire. So this will give us a roadmap to acquire the further sequences. So this is the standard T2 weighted and the T1 weighted imaging, sagittal imaging. So we have a 1.5 Tesla where I work. So we won't get the full spine in a single study. So we have to take multiple sections and compose them to get this. In a modern scanners, this can be done as a single sequence, which significantly reduces the time to acquire the image. Also, we can use the Dixon imaging. So that will a single sequence will give a T1, T2 stir and a fat sat image. So that will also reduce the time significantly. So this is the main sequence as far as trauma imaging concerned. This is stir sequence. This will brighten up the whatever the area of abnormality, be it a tumor, be it a trauma. So stir sequence should be included. This is the sequence I was talking about. This is called as an in-phase and an oppost-phase image. So selected cases. So for example, so the mechanism is, so this will, the fluid will be suppressed in this study. So you can see this is an irradiated spine. This is a case of pelvic malignancy with an irradiated spine. You can see the fatty marrow change involving the L5 and the sacrum. So this patient also had a trauma, a trivial trauma presented with the back pain, and there was a fracture in the L1 vertebra. So whether it is a pathological collapse or a compression fracture. So this will be a problem solver. So this is the in-phase and the opposed phase. So whenever there is a fluid, so it will suppress. So here you can see there is a signal dropout in suppressed phase, out of phase images, indicating this is just a benign collapse rather than a malignant collapse. So pathology in a pathological area or a fatty area will not be suppressed, and this will be brighten up. If there is a tumor here, so this will look like this. So the other image we can add in case of spinal trauma, the main limitation of this sequence is the time. So this takes around in a 1.5 Tesla, this will take around 12 to 13 minutes to acquire, which can't be done in every traumatic case. 3 Tesla, the time can be reduced. So this will give up multiple source images. There will be an ADC, FA, and a color coded image. From that, we can derive this beautiful tractography, which will clearly show the tracks going along the spinal cord. So this is a GRE sequence, a must in case of trauma. So this will show whenever there is a blood, when there is a hemorrhage within the cord, this will show as a hypointense signal within the cord. And this is a standard T2 weighted axial sequence. T1 weighted image is optional. So some cases when there is a gross hemorrhage, we can pick it up in a T1 weighted image also. CT should traumatic case should be read in multiplanar reconstruction. The axial images we will miss some fractures when we look at only the axial images. So it has to be read in a multiplanar reconstruction in a good viewing monitor to not miss a fracture. So few slides. The surgeons will be more will be expert in this. I'll show some cases. So spinal cord injury we can classify based on the level where it is occurring. Or the part involved. It can be an atlanto-occipital. In case of C-spine injury, atlanto-occipital, occipital condyle, cervical spinal fracture, posterior discoligamentous, facet joint. We have to look for a hematoma, cord injury, and a vertebral dissection. The mechanism, flexion, extension, and axial loading. Flexion is dangerous, or flexion is more unstable compared to an extension injury. So an unstable injury, the flexion unstable or bilateral interfacetal dislocation, flexion teardrop with wedge fracture with ligamentous rupture. And unstable extension injuries include odontoid type 2, hangman, extension teardrop, especially in extension. And Jefferson axle loading is a unstable injury. So this is sagittal CT reconstructed image clearly showing the atlanto-occipital dislocation. So the interval is clearly more than 4 mm in case of lateral radiograph and 2 to 3 mm in case of CT. This is clearly widened. So this case, MRI is necessary. We have to look at the what are the ligamentous injury here and look for the cord injury. This is occipital condyle fracture. I put this because sometimes the occipital condyle fractures will be missed when you look only at the axial images. So we have to look at the coronal images to rule out an occipital condyle fracture. So this is an Jefferson unstable fracture of the C1 vertebra, showing this CT image showing multiple fractures at the level of C1. So these few examples of a dense fracture, odontoid fracture. Type 2 is unstable. Hyperflexion injury. This is a common injury and it's an unstable injury. So the best diagnostic clue is the anteroinferior teardrop with widened posterior, widened interspinous space with distracted posterior jumped facet. This is an MRI image. So I put this to show. So this is a T2 weighted images. Here you can see the T2 weighted hyperintensity cord edema. So you need to have GRE images and to look for blooming to rule out a hemorrhagic cord injury. Sometimes if the injury is extensive and the hemorrhage is extensive, we can pick that up in a T2 weighted. This is stir image. The stir will show the edema. You can see this dark line within the area of edema. So this may not be seen in all the cases. So this will be seen only when there is extensive hemorrhage. The same can be seen in T1 weighted images also, but the best image will be a GRE image. The other case of flexion teardrop injury. So there is a anterior teardrop with posterior ligamentous disruption with hemorrhagic cord injury. So this is a case of the reverse hamburger sign in case of bilateral facetal dislocation. CT and MRI is to look for a cord injury. Hyperextension injuries, the best diagnostic clue is there is a widening of the anterior neural arches, anterior portion of the disc space associated with the prevertebral soft tissue widening. So sometimes if there is an associated rotational injury, we can see pedicoluminar fracture. An MRI will show a normal MRI will show a predominantly anterior soft tissue injury. So this is a case of C2 extension teardrop. You clearly see a large fluid and hematoma involving the prevertebral region with a relatively preserved posterior ligamentous complex. C-spine injury review areas. The first review area which should be seen before signing off the report or whenever you are seeing the image, you should look at this will not be seen in the sagittal. Sometimes if there is parasagittal is not given, you will miss this. You have to look at the axial T1 and the axial GRE images. So the flow wide of the vertebral artery will be seen as a hypointense. The vertebral artery will be seen as a hypointense structure. Whenever you see a hyperintense area, you have to look. The radiologist usually will add an additional sequence, T1FS sequence, to look for the dissection and a hematoma. But if you see a bright structure at the level of the vertebral foramen, you have to rule out a vertebral dissection. Sometimes there will be thrombus only, and we should not miss this. Thoracolumbar injury. So many classifications are there: Dennis, Evon, TL, ICS classification. But functionally, the functional unit of spine include an anterior portion and a posterior portion. So the anterior include the vertebral body intervertebral disc space with the longitudinal ligaments. The posterior ligamentous complex include the posterior elements and the associated ligamentous complex. So the injury morphology standard compression fracture burst. The TLICS include morphology of the fracture associated with then PLC and neurological status. So morphologically, the vertebral body include a compression, burst, translation injury, and the destruction injury. And the PLC integrity, you have to have an CT, but MRI sometimes a few cases there will fractures will be very small, and MRI will aid in the detection of the edema involving the interspinous and the supraspinous region. So this a case of compression fracture of the thoracolumbar vertebra. CT, the main drawback is sometimes the height may be maintained. So the advantage of MRI is sometimes few cases. So this will pick up additional fractures, especially medico-legal. The first report may have the CT report or a first report may have a certain number of fractures, and the further MRI can have we can pick up more fractures. So they have to be clear. CT can miss some type of fracture, some simple compression fractures. So this is a burst fracture with a retropulsed fragment. So this is a stir image clearly showing the anterior fracture with an associated posterior ligamentous injury. Sometimes there will be only edema involving the interspinous region. A few cases we have seen when there won't be any bone edema, just the supraspinatus, and when you retrospectively the X-ray will show the widened interspinous region. So few special cases. So this is an ankylosed spine. So ankylosed spine, we have to be double careful. So there will be small fractures which will be missed, and a casual reading can miss this. Fracture. Shibora, especially in pediatric cases, there will be without radiological abnormality. MRI will show MRI may show cord changes. This mainly due to immature nature of the skeleton in pediatric patients. The other is in case of this is more towards spinal rehabilitation. So the patient with extensive spinal trauma, they will develop post-traumatic searings. These cases, MRI, if there is worsening of neurology, these cases will require a CSF flow study. Sometimes there will be arachnoid granulation or some fibrous bands which will block the CSF, which can help the patient. So these patients, whenever there is worsening neurology, MRI is indicated, and when we see a new or a progressive searings, we have to consider CSF flow studies. Other is ventral cord herniation. So the MRI will clearly show this focal anterior displacement of the cord with expansion of the posterior subarachnoid space. This is there are many theories. One theory is due to ventral there is a defect in the dura through which cord is herniating. The other this CT can miss this epidural, and sometimes you can see the subdural hematoma in the brain. In a complex injury, MRI is always indicated once the patient is stabilized. We have to do an MRI to look for epidural and epidural hematoma, especially in anterior and posterior epidural hematoma. Apophyseal ring fracture is a rare variety of injury, especially seen in pediatric cases. So the limbus vertebra usually anterior. When you see a limbus vertebra-like configuration with an osteopathy in a child after trauma, you can think of an apophyseal ring fracture. But not to miss vascular injuries. This can be missed in case of in the initial MRI. When there is a hemodynamic drop, they don't hesitate to do a CT angiogram or a DSA. This post-traumatic IC occlusion and delayed presentation of a post-traumatic dural AV fistula. So AV fistula, even MRI, CT angio may be negative, and DSA is the only modality which can pick up these AV fistula sometimes. Few words about cord signal change. So cord signal change can be seen in case of after trauma or can be seen in non-traumatic also. So this is more of a neurology part. In case of a compressive cord signal change, so I put this image because sometimes the mid-sagittal section, we won't see the cord injury. You have to look at sometimes you have to look at the paraspinal region. to pick up subtle cord changes, especially in a spondylitic spine after a trivial trauma, and the neurology is not corresponding to the imaging characteristics. You have to look at carefully. Few centers, when there is the radiologist not there, the technicians usually put the axial images at the level of disc level, so they won't put it as a bunch. So the axial images can miss it, and if you look at the mid-sagittal images, you can miss this cord change. So always look at the parasagittal images, and especially in a spondylitic spine. So this image I showed early. This is a DTI. As I told, the main problem with the DTI is time. It takes around 12 to 13 minutes to acquire this image, and the post-processing is difficult. Unless you have the softwares, it will be difficult to process this. So this is the FA image, and this is the tractography. What we see in the monitor is, we see this image, but we can't give all these images in imaging plates. We will give only this tractography. So here you can see a subtle edema in a spondylitic spine. You can see a subtle edema here. So this is the color coding. So this is a normal spine, a normal spinal cord. You can see the color correlating to so this greenish yellowish tinge. So at the level of cord edema, you can have this. So this is especially used in case of non-hemorrhagic injury. So here you can see this reduced signal corresponding to this purplish hue. When you go back, when you measure the FA values there, the FA value will be reduced compared to the adjacent normal cord. But tractography, unless there is an extensive disruption, tractography won't. This. So what we see in the DTI, so these are the four things. So these two we see most in tumors. So as far as deviation and infiltration we see in most in mostly tumors. So as far as trauma is concerned, we can see a destroyed or a disrupted pipe. But non-traumatic spinal cord edema, there will be reduction. You can see this tractography image. So to summarize, as a radiologist, the main thing is we have to finish the scan as soon as possible, because some of these patients can't lie in a scanner for a long time. Never miss a vascular or a hemorrhagic cord injury. Use additional sequences whenever necessary, like DTI, because time consuming in selected cases. And some sequences like 3D images or an in-space and an oppospace images can be used as a problem solving tool, especially in a case of in a patient with a known malignancy. So these can be helpful to prevent unnecessary biopsies. We use a lot of in-space oppospace images at our center along with diffusion. So that will help us. That has actually reduced. That helped us in reduce the number of biopsies unnecessarily. Thank you. So, any questions you can ask. I'll be happy to answer.
Thank you very much, sir, for this wonderful presentation. We have some questions which will be shared to us very soon.
Okay.
And Dr. Panikiran, sir, please.
So, thank you, Dr. Kanagasabai, for the very good presentation. I just had a couple of questions. One is, what do you think is the right time to do this functional imaging tractography? Is it necessary to do it in the immediate post-trauma, or it can be done even after the patient is stabilized and post-surgery even? Is there any difference?
Yeah, it's not absolutely necessary to do in an acute setting. So the acute setting, we have to rule out whether it's an hemorrhagic or a non-hemorrhagic injury. So DTI mainly used as a prognostication, already spondylotic spine. So we are not sure whether it's a chronic change or an acute change. So these kind of cases we can use.
And sometimes when the patient is a bit unstable and needs monitoring, there is in certain centers there is a difficulty because the MRI may not have the monitoring facilities. What do you suggest in such situations?
Monitoring as in a radiologist or a anesthetist or a
the equipment, the equipment which can be monitored, the pulse ox and things like that, which can't be taken inside the MRI rooms.
That's a very practical difficulty. High-end centers, like we have a full MR compatible set. We have a pulse oximeter, we have a MR ventilator, we have a full oxygen tubing, and a whole ICU can be shifted to the MRI in a hospital like our setup. It's better to be safe than sorry in those cases, especially if the patient is not stable. It's better to be safe than sorry.
Yes. So I think the message should be that it is better to stabilize the patient, do the initial ABCs, and then probably one should not rush into shifting the patient for CT and MRI when they're unstable.
Yes.
Regarding the vertebral artery injuries, sorry.
Okay. Sometimes we pick up it may not be seen by the orthopedician or the spine surgeon. Like from the ER, they send for a brain MRI. Brain MRI protocol, we usually follow till C2. So I have picked up few cases and I asked them to call the caller. I asked them to bring the caller, and after a few hours, the patient will be put on caller in the CT or MR table.
So sometimes there is a rush to do the imaging first before stabilizing the patient. That is very important. I had a question about the vertebral artery injuries. Like you have shown a couple of cases. But if there is bifascial dislocation and there is a tortuous course, how reliable is the MRI in picking up if there is any vertebral artery? Usually it is more likely to happen when there is significant displacement. Of the
so vertebral artery dislocation. So if there is a monitoring, we will do as additional sequence. So we should use the thin T1FS sequence. So that will show the dissection and the hematoma clearly. Most of the time it will be missed. To be frank, most of the time it will be missed because we do the axial sequences only at the level of disc. So the training should be more. The spine surgeons and should insist on these sequences, especially in a high in a good setup. In a good setup, the radiologist will be there. He will pick it up. In a semi-rural setting or a rural setting, whoever is referring should be able to know that we have to put in additional sequences, especially in these cases. Unless if we don't do those sequences, there is a high chance we might miss it.
Thank you.
Yes, sir. We are actually collecting some questions from the audience side. Mr. Rishi. Okay. Meanwhile, this is Dr. Panikiran, sir. We have had some delay in introduction. So Dr. Panikiran, sir, is the head and the senior consultant in the Gleneagles Hospital. He's a spine surgeon. And along with as panelist, me and Dr. Keerthivasan, we both are spine surgeons from Kauvery Hospital, Alvarpet. And one thing what I would like to state here to all the young and upcoming surgeons here is, it's absolutely best to have a very good cordial relationship with your radiologist, and they will pick up good information, even trivial informations from the imagings for your patients. And sometimes we, as experienced surgeons, we might fail to understand. So me and Dr. Keerthivasan, sir, we usually have it as a thing to just go and visit him whenever we have time to see. We will be able to discuss some of the cases, some of the surgeries we are about to do, just for the sake of it. And it was a good, we'll have a good fun chat for another 10-15 minutes. And in that time, we learn a lot from Dr. Kanagasabai sir and his team. And that is how we build our experience in reading these images and these advanced imaging techniques in MRIs and scans. It's interesting cases. And there are many times we would have failed to notice some important information, and he would have picked it up for us, and he would have it ready. It's a very honor and pleasure to have Dr. Kanagasabai with us. And I'm sure that all of you in your centers will have good reputed radiologists who will be able to help you in this venture. And meanwhile, we haven't understood. Mr. Rishi, are you online? I think there are no more.
I have a question.
Please, sir, go ahead.
Dr. Kanagasabai, we always, as spine surgeons, we have this debate sometimes in burst fractures where there is about posterior ligamentous complex injury. Some of the studies and some people believe that the MRI sometimes may overstate the status of injury and lead to surgeries where probably it could have been managed conservatively. What is your idea about that?
Yeah.
The reliability of MRI in predicting the real actual PLC injury, does it really overestimate the injury to PLC?
The main thing is sometimes the patient lies there for a long time. There will be subcutaneous edema and soft tissue edema around that area. So that sometimes will be misinterpreted as a PLC injury.
கொஞ்சம் சவுண்ட் மட்டும் பிரச்சனை இல்ல போட்டுங்க சவுண்ட் மட்டும் கொஞ்ச நேரம் மீட்டிங் முடியறாரு.
This is the frequent argument we have about the PLC injury. Sometimes we say I will call it as a PLC injury, and Keerthivasan won't accept it. Recently, we had a case. I showed him a fracture in CT. I told him that I picked up an extra fracture and showed him it's a PLC injury. Sometimes it's there. The main thing is to have a better cordial relationship between the radiologist and the spine surgeon.
But the relationship is more important between clinical features and radiological features than between a clinician and a radiologist.
No, in a way, if you overestimate the PLC injury, it's good for the surgeon.
Yeah.
But
Yeah.
but yeah, that's important because sometimes there are patients which we may be able to manage without surgery if the PLC is intact. So that's important to identify.
The other area we'll have our fight is after endoscopic surgery. We'll say it is a cavity. We'll say it is a recurrent disc. These are the common fights we have.
Any further questions from the audience?
Yeah, as of now, no further questions from the audience, sir. Dr. Any questions from your side?
Soma, sorry, I can't hear you, Soma.
Yeah, there's from the audience side, they haven't still collected the questions. It's still on process. The people in the audience, you're free to send in your comments, your questions in the comment section below. Our team will collect these questions and relay it to us. Meanwhile, Dr. Keerthivasan sir, if you have any questions, we can continue. Kanagasabai sir, as you had mentioned before about the 3 Tesla, 1.5 Tesla, apart from the difference in the speed, the duration of this the routine, what other benefits do you feel is much more in these latest advanced machines?
Main thing is speed, and I personally feel 1.5 Tesla is better for spine. spine imaging, especially this GRE image. In the case of trauma, GRE is not good in GRE 1.5 Tesla. All the gradient images will be good in 1.5 Tesla rather than a higher Teslas. That's one advantage. The main thing is the composed images. In our center, we have to do 3 stacks to get a single spine. So if it's a spine screening in a trauma case, we have to do cervical, dorsal, and lumbar separately. So that takes a lot of time. So whereas in a higher scanner, we can do it in the single acquisition, and we can get multiple images from that single acquisition. So 3 Tesla is absolutely, as far as not much of, especially except for a minor change in the quality, not much of difference, but the duration of the scan is much reduced in case in a 3 Tesla compared to 1.5 Tesla. 1.5 Tesla is diagnostic for a spine trauma. You don't definitely need a 3 Tesla to for most of the cases, except some cardiac case. For a routine imaging, 1.5 Tesla is enough.
Can I ask a question?
And with the new onset of yes, please go ahead.
I just wanted to ask if what would be the main difference between the GRE sequence and the STIR sequences? What's the advantage or pros and cons of these two?
No, they're entirely different. STIR is mainly for edema. STIR is mainly to pick up the edema. That is the workhorse. So whenever there is we'll pick up all sorts of edema, infection, inflammatory. This GR image, this will show the blooming. And this GR image was developed. We can show the disc also. So the disc will be the disc will be high. When you look at the C spine sequence, so we have a GRE axial, not a T2 or a T1 axial. The standard protocol is GRE.
It's mainly for looking at this cord. Inside the cord, if there is any condition.
Yes, inside the cord, and
GR is better.
Inside the cord, and the disc GR is better. So we're looking at the vertebral marrow and the ligamentous complex. STIR sequence is better.
STIR is better.
Sir, as we were discussing about this PLC injuries, with the advent of these standing MRIs and flexion MRIs, dynamic MRIs, do you think they'll play a bigger role in the future in assessing and precisely diagnosing these PLC type of injuries?
Yeah, definitely, but only in a stable patient, not in an unstable patient. It can be helpful, but not much of. We don't have practical experience in India as far as this dynamic MRI is concerned. It's still in few centers they have in Western countries.
Yes,
it's definitely better.
The query, the doubt usually arises in patients with relatively stable, clinically stable patients who are able to stand, we can do a dynamic with very subtle changes which we'll be able to see. Those are the patients where we get in doubt in a normal MRI.
Maybe in osteoporotic fractures, senile fractures, to find out the painful levels, we may utilize that in the future.
Main thing is cost, and we're not anywhere close to installing for mass use in India as of now. Only dynamic MRIs and the peripheral extremity MRIs.
Okay, sir. So with this, we have come to the end of this meeting. I would like to thank Dr. Kanagasabai for spending his valuable time in the evening for us. And I believe he has shared very valuable information that will be useful for most of our spine community and spine surgeons. Thank you, Dr. Soma and Dr. Panikiran, sir, for sparing your valuable time in the evening and for your valuable questions, which most of us have the doubts. Thank you all. Thank you, sir.
Thank you.
Thank you, sir.
Thank you for having me in this.